Dear audience, let me share my PhD project on metabolic changes in pancreatic disorders. I'm Mónika Lipp, a PhD student and a gastroenterology resident at Semmelweis University. My personal vision is to take action on the quality of care. Here you can see our ongoing projects. In our first project, we try to understand the connection between fatty pancreas and pancreatic carcinoma. In our second project, we examine the metabolic changes in pancreatic disease progression. And in our third project, we will conduct a clinical study on sodium bicarbonate supplementation on healthy volunteers. Let me focus on our first project on fatty pancreas and pancreatic cancer. It is known that pancreatic cancer takes the first place among asymptomatic cancer. It has also been shown that pre-existing metabolic disorders can contribute to the development of pancreatic cancer, and somehow fatty pancreas plays a role in this process. Our aim was to detect the association between fatty pancreas and pancreatic cancer. We wanted to know, does fatty pancreas predispose to the development of pancreatic cancer or not? We conducted two analyses where we wanted to know the ratio of pancreatic cancer and the ratio of fatty pancreas as a main outcome, with the hypothesis that fatty pancreas increases the risk of pancreatic cancer. We conducted our systematic search and selection in 3 main databases with the final search key you can see below. After our systematic search and selection, we ended up with 17 eligible articles for our meta-analysis. And let me present you some of our results. Here we investigated the presence of pancreatic cancer among patients with fatty pancreas. The odds ratio is 1.32, which means that it clinically could be important, but it's statistically not significant. That's why we changed over the question to see the real connection. Here, we investigated the presence of fatty pancreas among patients with pancreatic cancer, because fatty pancreas maybe later can progrediate to pancreatic cancer. Here, you can see that the odds was more than 6 times higher compared to the control group. It is clinically significant and it is also mathematically proven. The connection is there. In conclusion, from other studies and from our meta-analysis, we can say that fatty pancreas predisposes to the development of pancreatic cancer, and the odds of having fatty pancreas among pancreatic cancer patients was more than 6 times higher. The implication for practice would be the standardized measurement of the fatty pancreas, and the implication for research would be that more prospective observational studies are needed on this topic. Here you can see the status of our manuscript. It has been published in October in the Journal of Cancers. Let me focus on our second project on metabolic changes and pancreatic disease progression. It has been shown that on admission and peak in-hospital glucose levels are independently and dose-dependently associated with AP severity and mortality, acute pancreatitis severity and mortality. On the right side of the slide, you can see that BMI above 25 increases the risk of severe AP, while BMI above 30 increases the risk of mortality. Our aim was to understand the different parts of the metabolic syndrome in this process. We wanted to know that what are the main factors that contribute to the development of recurrent acute pancreatitis, early chronic pancreatitis, or even pancreatic cancer. We included patients from the GULASH trial. In GULASH trial, patients are admitted with acute pancreatitis, and in GULASH Plus trial, we are following these patients until the 6th year every year. And our main outcome of interest was the ratio of newly developed pancreatic diseases, with the clinical implication that we would like to prevent and detect early these diseases. Let me show you some preliminary results. Here you can see the on-admission morphology of the goulash plus patients. You can see that 3/4 of the patients presented with acute pancreatitis presented with their first attack, and the remaining quarter of the patients presented with already advanced pancreatic morphologies. Let me present you the progression of diabetes through the years. In the first pie chart, you can see the acute pancreatitis group and the diabetic status of that group. Marked by green, you can see the normal diabetic status patients. It is more than half of the patients. And if you follow the pie charts at the end of the fourth follow-up year, you can see that only 1/4 of the patients will present with normal diabetic status. If we focus on the chronic pancreatitis group who already presented with chronic condition, it was like less than half of them presented with normal diabetic status, and at the end of the fourth follow-up year, I would like to highlight that more than half of them presented with already diabetes. We are at the statistical analysis phase now. And in our third project, we try to understand the sodium bicarbonate supplementation on healthy volunteers. It is known that chronic pancreatitis causes pH imbalance and it leads to exocrine pancreatic insufficiency. The gold standard therapy is enzyme replacement therapy, but there are some side effects as well. So we would like to know if sodium bicarbonate can be potentially effective in this kind of disease. We wanted to know that does sodium bicarbonate supplementation in capsule form or in non-capsule form changes the pH in the stomach and in the duodenum. We will include healthy volunteers, and half of them will receive sodium bicarbonate in capsule form, which dissolves in the duodenum, and the other half of them will get sodium bicarbonate in non-capsule form, which will dissolve in the stomach. And we will measure the pH. And our hypothesis is that sodium bicarbonate in capsule form elevates the pH in the duodenum. Here you can see the methods. We will include 20 healthy volunteers, and we will give them like different dosages of bicarbonate in capsule form and in non-capsule form. We will use 4 arms, and we will measure the pH during the day. We will start this study in July. As a summary, I would like to highlight that we were able to strengthen the connection between fatty pancreas and pancreatic carcinoma, and we published an article in last October. In our second project, we try to understand how the metabolic changes contribute to the development of pancreatic disease progression in a form of clinical trial analysis. And in our third project, we will conduct a clinical study on sodium bicarbonate supplementation on healthy volunteers, which will be started in July. Here you can see my additional activities. Through the years, I was working together with my wonderful team. I had an extraordinary TDK student, Jimin Lee, and I was able to present my topics on several national and international conferences. Well done is better than well said by Benjamin Franklin. Thank you for your attention.
Well done so far. Congratulations to your paper too. If I can start the questions, can we go to your second forest plot, the pancreatic? Okay, this one. I mean, the heterogeneity is very wide. I mean, on one side, this is really very important. This is a very important observation. On the other side, I mean, like the last study, I mean, everybody is fat who is actually in the cancer group. So, what's the? I mean, so there might be a bias actually on in a certain studies. So, how do you explain this?
Yeah. As you've seen, we were able to include only 17 studies. So there is a quite new topic. There aren't enough studies on this topic. And if we focus on the heterogeneity, we can say that sometimes patients were included who had just a regular visit at the hospital, and there they checked if they have fatty pancreas or not. And in other articles, they included patients who already had some pancreatobiliary dysfunctions, and that's why they had an EUS and an ERCP. And there were other studies where they included patients who had like a previous operation on pancreatic cancer. So it's also added to this study as a confounding factors. And as you already said, the heterogeneity was quite high, but we really tried to focus on that articles which can be put together, and it was like a really pre-selected range of articles, and that were the articles which were the most similar to each other. So that's why I emphasize that further prospective studies are needed in this topic.
Congratulations. I have a question related to your third project.
Okay.
Could you please go back to the hypophysis, because something is not fully clear for me, maybe only for me, because it says sodium bicarbonate in capsule form elevates the pH in the duodenum. So does it mean that sodium bicarbonate in non-capsule form doesn't elevate, or or you would like to say that it elevates more than the other version?
Yeah, thank you for your question. We don't really know. We will start this study in July. But regarding to your question, I would like to say the second one, what you mentioned, that we are waiting that sodium bicarbonate in capsule form like elevates more, because if you give sodium bicarbonate in non-capsule form, it will dissolve in the stomach. So we don't really think that the effect of the sodium bicarbonate can reach the duodenum. So that's why it's a quite new thing to study this effect, because there is a new capsule which dissolves in the duodenum. And we would like to measure that, is it like measurably effective? So do we see like real pH changes, or is it possible to detect the pH changes in the duodenum in this short period of time, because maybe it will dissolve not exactly there. So that's why we also would like to know that sodium bicarbonate in non-capsule form elevates the pH at all in the duodenum, and what is the effect of the capsule form? Does it elevate this enough? Does it elevate it at all? So that's why we will conduct this study, and we will start in July. So I don't really have like preliminary data or something like this, but it really wasn't easy to organize it, because it's quite a new thing, and we hope that we will see some results.
Thank you. Much.
Thank you for the really nice presentation. I would like to ask only that, what is exactly fatty pancreas?
Yeah, thank you, because so it's really important to know that how can we distinguish between a normal pancreas and in a fatty pancreas. Fatty pancreas is a fat infiltration to the pancreas, mostly due to obesity. So we will find like fatty pancreas more in the obese patients, but in an average population, it presented 30 to 35% of the patients. We can say that up to 6.2% fat content in the pancreas is normal, and above them we can speak about a fatty pancreas. And somebody would like to know, is it like the same as fatty liver or is it different? And I can say that when we speak about fatty liver, the fat content is within the hepatocytes, and when we focus on the fatty pancreas, the fat content is in the intracellular space, so intercellular space, so not within the cells, like between the cells. So the development of disease, I think it's a little bit different, but there aren't enough study to compare these two entities and to have like enough knowledge based on like these already published articles.
What do you think is the mechanism between fatty pancreas developing to carcinoma?
Yeah, thank you. I have a slide about it. So this slide is about like Syrian golden hamsters who got like BOP is a pancreatic carcinogen like injection, and if these rats was put on standard or high-fat diet, you can see that the intralobular adipocyte area was different after like 14 weeks and after like 25 weeks. So you can see that these hamsters who was fed with high-fat diet, they more likely presented with like a greater percentage of intralobular adipocyte area after 14 weeks. But if you focus on the 55 weeks results, you can see like even a bigger change. If I focus on your question, there are some studies about how like obesity causes cancer, and it can relate to the stress response, what's in the area, what causes the damage of the adipose tissue. So these are like well-studied mechanisms, but not well studied in the form of fatty pancreas. So that's why we are like somewhere here we have like animal studies, but we also need more like basic science studies.
Thank you very much.
Thank you.
So congratulations. I just want to ask concerning the third project, how can I imagine that measurement, pH measurement, how do you plan to perform it?
Yeah, thank you. So regarding to my third project, we will use a pH catheter, which was previously used in previous studies and in practice to measure the reflux disease. And is it a dual channel pH catheter? So we will position the catheter different parts in the different parts of the system. So the first part, which will measure the pH, will like put in a stomach, and the other part will be inserted in the duodenum. So it's a long catheter, and there is 2 points where it can measure the pH. So at the beginning of the day, we will insert this catheter, and this catheter has attached to a pH measuring device. And this device communicates with a laptop, and this system is able to detect these pH changes like 4 hertz per second, so like we will have so many data, and after that we will give them like after 1 hour the first dosage of intervention, and we will like see during the day if the catheter is in the right position or not, because it can cause like biased results, because when the pH measuring part will like go to the both part will go to the stomach, it will give like a biased result. So that's why it's really good that these pH measuring parts are visualized with X-ray, so we can check the position of the catheter during the whole day. And you can see that after 5 hours they can get the next dosage, and after 5 hours we will continuously measure the pH during the whole day, and we will remove the catheter at the end of the day. The patients are not allowed to eat or drink. We will give them infusion during the day. So we would like to like eliminate these kind of biases which can lead to like biased results. So that's how we would like to do it. Thank you.
Thank you.
So I got 2 questions. First of all, about your last topic, where I would like to ask the bicarbonate in future, it should be like add-on therapy to enzyme or alternative one?
Mm-hmm.
And the second question is about your first topic. You mentioned a strong association between fatty pancreas and obesity. Did you find any studies where they adjusted for obesity and show that fatty pancreas is independent risk factor for cancer?
Okay, thank you for your questions. Regarding to your first one, we will see. So I don't think personally that it can be like a total replacement of the currently existing enzyme replacement therapy. We don't really know what will be the pH changes which this capsule will cause in the duodenum. So the optimal scenario would be that it's like a new thing and it can like replace, for example, enzyme replacement therapy. But I think that maybe it can be like an additional therapy, but we will have to see the results from our study. So we haven't done any study with any day with a volunteer yet. So after July, I can tell you more about it. And regarding to your second question on fatty pancreas and obesity. Yes, in that topic, there was a previous meta-analysis which examined like fatty pancreas and diabetes, and they also had data about obesity. And it has been shown that I couldn't tell you that is it like an independent risk factor or not, but it has shown that fatty pancreas presented more in like obese patients, and it's related to diabetes as well. So I think it's a really complex process, and it's hard to just pick one element, just pick fatty pancreas, just pick obesity and diabetes. So somehow we have to like focus on the whole process. In our meta-analysis, we weren't able to extract like data regarding to obesity or diabetes. The data in the articles was like so heterogeneous, and not every articles mentioned them among the patient characteristics. So that's why it's missing from our meta-analysis. But I really hope that in the future there will be more studies and we can tell you more and to everyone more about this connection. Thank you.
Basically,
Thank you.
congratulations. It was a very nice presentation. Basically, I have almost a similar question just on the BMI. So
Okay.
in these studies, don't you have data on the BMI? Because it would be nice to know the BMI association with the fatty pancreas, whether it's obesity or not. So that's another point. And mainly obesity, of course. But in cancer, when it develops, then the patient, they lose weight. So, and usually it's diagnosed when they are losing weight. So it would be nice to know an association between the BMI, fatty pancreas, and the pancreatic cancer.
Yeah, I can say somehow the similar answer because we don't have like enough data, but we really wanted to like pull together this data. But there were only some articles which reported on BMI. Some articles just reported like BMI above 25, and some articles like distinguished between like pre-obesity and obesity groups. So that's why we weren't able to have like this kind of data because we couldn't like pull together this kind of data. So it's a really important questions, and at your second part of your question you focused on like the weight loss during pancreatic cancer, and it's also a really important part of that disease, but these studies weren't able to get us data about this process. Thank you.
So we have this exclusion criteria and
Okay. Yes.
yes, again. So these are different categories, or somebody has to have hypokalemia, metabolic alkalosis, chronic organ failure, and so to get included, or these are subgroups?
No. So patients, so volunteers who has hypertension or chronic organ failure are excluded. So they are, or maybe I had to put like or.
Got it. I just misunderstood. You see.
Yeah, and it was like a really hard part because we wanted to start our investigation in this month. And at the like one day before we started, one volunteer came up that, oh, sorry, I have a hypertension. So that's why we had to cancel the whole day. And I hope that in July we can really start. Yes.
Yes, a nice presentation. I enjoyed very
Thank
much.
you.
So I'm a surgeon, and the first question is: you reported about the relationship between fatty pancreas and cancer.
Yes.
These data, I missed that in your talk. How was the diagnosis of fatty pancreas? Was it done in specimen after surgery?
Yeah. I will show you a slide. So most of the studies have done EUS as a diagnostic method, and other studies have done CT or MRI, and only one or two studies have done like a histology sample to distinguish between is it a fatty tissue or not. The gold standard is histology. But with EUS and CT and MRI, we also can detect. These are like less invasive. So it wasn't like a study where they've done pancreatic cancer surgery and they've taken like a sample from the pancreas. The one histology related study was from autopsies. So after the surgery, and with EUS and with CT, you can distinguish. With EUS, you have to like measure the echogeneity between these between the spleen and the pancreas. And at CT, this pancreatic spleen ratio has to be below 0.7. So, but it wasn't like the same in all articles. So I'm really glad that you asked this, because there were like different diagnostic methods.
Understood. Now you are an expert in fatty pancreas. So normally I have no idea about fatty pancreas at all. So you are my expert. If we talk about liver diseases, we have scores, child A, B, C. If you say fatty pancreas, yes or no, or are there any scores available in the literature, or are there any, let's say, rating?
There is no rating, as far as I know, but there were articles where they distinguished like fat content above 10%, and where they like distinguished further these groups like 25 or even more, but there is not a standardized measurement and standardized value, so that could be a further implication.